Mullins, that's me, National Programme Director for IAPT, Department of Health. Okay. This is really my summary of the 4-year plan, Talking Therapies. You will have seen what we're trying to do in terms of the overall programme, so that's basically there's two elements. We're trying to roll out the national programme to improve access to psychological therapies for adults, and then we've got various aspects of expanding access for improving access to psychological therapies in various areas. What we plan to do is obviously create capacity in terms of the workforce. We work to very specific quality standards, session by session outcome monitoring, step care model in line with NICE approved therapies, and we offer flexible referral routes. So the areas of extended scope which I'm going to come to are children and young people, people with SMI, people with medically explained symptoms, and people with long-term conditions as well, and this thing called MUS. Yeah? What we're focusing on is obviously improving access to relatively standardised treatments, particularly for anxiety and depression. We're expecting that will improve health and well-being, and that's an important flavour, I think, to come back to the context of the future. And we expect more of this sort of user engagement and involvement in designing and delivering services, quite interesting in peer support arrangements, which might be a theme we want to come back to too. And we expect people to return to normal working lives, whatever that might mean. And he said some of the benefits of that are not only to individuals in terms of improved clinical outcomes, but making a contribution back to society and actually paying for some of the interventions that actually need put in place. Where we're at the moment, 3.2 million people have come through services, 2.5 million completed, 1.3 million overall have moved to measured recovery, and 75,000 retained jobs. That's where we want to get to. The big figure at the bottom is the one that will pay for this endeavour. That's one of the things we expect to do. That's where the 700 million will come from. This is really my very crude model for what we're trying to establish. So on an annual basis, according to the Adult Psychiatric Morbidity Survey, there's something like 6 million people out there in need with common mental health disorders, primarily anxiety and depression. That's a very, very substantial, big number, really. Those people are quite stressed, and we reckon we can establish a system on an annual basis can address 900,000 people through the services. So address 900,000, 15% of that need. That's a fairly modest aspiration. There's all sorts of reasons for that, but that's what we're aiming at. What we expect is that 600,000 of those people will complete the course of treatment, 300,000 will recover, and 25,000 will move on benefit. That's roughly the system we're trying to create for adults, in a nutshell. What we've been doing is performance managing the system to death in order to achieve that. So you get a sense of where the prevalence sits. Obviously, it's roughly it's fairly evenly distributed across populations. So London and the North West, the biggest regions, have the biggest share. And the aspiration of the 900,000 bottom right-hand corner, that's what we expect each local economy to be able to deliver on an annual basis. And that's being performance managed through the NHS using what levers we've got at the moment, and they're about to change clearly. But we currently have the NHS operating framework, and there's two very important indicators in there which we expect services to deliver on, local economies to deliver on, around access and around recovery, but also to begin to extend the scope of severe mental illness and long-term conditions. And we're very important aspect of this is making sure that access is equitable, particularly for members of black and minority ethnic communities and vulnerable people. What we've been focusing on, and if you like, cracking the whip wherever we can, supporting local economies as well, is around making sure that our key performance data is submitted. And it's quite extensive, gives quite a level of insight into what's happening in local economies. It's all publicly available, all information sent to websites, should you wish to go that way. And we focus on where access numbers are beginning to fall below green trajectories. We get in there and try and help, understand, support. We're very interested, and it's improving, actually, the number of treatment completions will begin to tail off. Very important, people start treatment, they complete, they get the full benefits of it. And if recovery rates begin to dip, we take an interest in that. And we've got an issue on our waiting list, which I'll return to in a second. That's roughly how we go about the performance task for the adult programme. This is where we are at the moment. You can't see some of the slide, but what I'd ask you to do is just look at the gradual increase in these charts as you go through, with a couple of exceptions. So the first chart, the top chart there is about numbers of accessing treatment. As you'll see, a steady rise. Slight dip in the last quarter, so that's Q1 of this current financial year. It's provisional numbers, so they may go up a bit, although I doubt it. So there's no, I'm worried that we may have actually sort of crested the wave there in terms of increasing access rates. The run rate we've got at the moment is about 600 in an annual period, 600,000 in an annual period coming through services. So that's a way to go to hit that figure of 900,000. Treatment completers were tailing off, but now beginning to improve, so that's why it's gone slightly back up again, right at the end of that chart. We're also beginning to see improvements in the numbers of people coming off sick pay and other benefits. So we were beginning to achieve that 25,000. Run rate is somewhere near that, so about 20,000 at the moment. So a bit of a dip in the last couple of quarters, which is slightly worrying. And the question of whether we're actually getting to what people are actually more difficult to treat, more difficult to introduce back into the world of work. We need to understand that a bit more fully, I think. What's really worrying now, and we're sort of clearly a victim of our success here, is the number of people waiting. So we have sort of a target, it's an indication. We expect people to be able to pass through the service, receive treatment within a 28-day period. And what we're beginning to see is an accumulation in weight. This is only a snapshot, mind you, so it's not entirely a robust indicator. It's a snapshot at the end of the quarter. So the figure has leapt over the last couple of quarters from 90,000 up to 120,000. And that's of significant concern. We think there's some validation issues in the last quarter, mind you, so these provisional figures may come down. But it's an area I know our minister is particularly interested in at the moment. So I may want to come back to that. What's really encouraging, and I think I'm this, along with the Olympics, when I started, the recovery rate that was in this sort of blue area, which you can just see in the middle there, in 10 and 11, probably staying below the 40%. As soon as I arrived, it slipped above 40%, up to 43, and it's consistently driven up from there. So that's quite encouraging. So consistently now, we're achieving recovery rates for people who treat a complete course of treatment in excess of 45%. Bear in mind, we're aiming for 50%, that's very reassuring. And when you look at the numbers of people who are benefiting, so in the last quarter, 35,000 people got better as a consequence of the IAPT initiative. That's tremendously encouraging and rewarding for all those involved. Where we have a worry, this is just, I want you to look, if you look at the final column there, this change, rather than what the detail there, is that we are beginning to not commission sufficient capacity going forward. That's the theoretical assumption here. We thought, in order to have sufficient capacity to create that system with 900,000 people accessing, 600,000 being treated, we expected to have growth, grow the workforce by at least 800 a year over the last couple of years and next year. And we're actually somewhere short of that. So you see particularly acute sources beginning to appear against that planning rubric in high-intensity treatments. So we may not have sufficient capacity going forward, and that's an anxiety. We're putting pressure on the system to increase the level of training commissions and increase the level of recruitment into training places, which is to be the critical issue. There's all sorts of uncertainties in the economic environment. People, when they're high intensity, they tend to be in a job and go for additional training. Should they make the leap, shouldn't they? And all those uncertainties creep in. I think there's a little issue there. We're doing not so badly, although we could do better on low intensity. These tend to be people who are not in employment, coming into training and then getting a vocational career out of the training. Doing quite well in terms of increasing the range of choice in the therapies. We've now moved away from CBT and now offer a number of counselling and psychotherapies in the IAPT services. We're doing very well in our supervision. So there's a bit of a mixed bag, but the real anxiety is that we won't have sufficient high-intensity therapies going forward to hit that capacity aspiration in line with the test. So we're putting quite a lot of pressure on education commissions and services in order to achieve that. Money, quite a lot of money in the service to do this piece of work. People talk broadly about 400 million being invested, but we've actually had a few additional sums coming in, particularly 2 million people, and 22 million coming. It's in excess of 450 million if you add up the numbers on there. So we're making a huge investment as a central initiative in this programme, and we expect obviously a significant return from that. So money for once, in one place, one small part of the NHS is not the issue. It's getting delivery is the issue in an otherwise uncertain environment. So just to make sure that you understand where we sit, we have got a very direct line of sight to our Minister, so Minister of Care Services, Norman Lamb, just being close. Very clear arrangements for keeping an eye on with other programmes. So we sit down at the bottom with all the other work streams, we report into a thing called the Ministerial Advisory Group, which is responsible for delivering the overall mental health strategy, and we're a key implementation strand. So there's nowhere to hide in particular for us, I think is the point. That's my team. I mean, we can't see the detail, there will be some names in there you probably recognise, because a number of you want to be in the service for longer than me. Top is my national clinical advisors, people like David Clark, Peter Folligy, those sorts of very eminent individuals very influential in designing the programme. And then the delivery bits all down the bottom, which is largely where I focus my efforts and time. This is just a series of activities, but on the left there's a basic programme on the left. You can see where we're focusing on performance management assistance of Dept, hit 15% to 50%, increasing the range of choice. That's the top box, which we've got various work strands attached to. The thing that's really exciting, it sounds boring, but it's really exciting going forward, is the incredible amount of insight we're now getting as a consequence of the improvement of data flows that we've got in services. All of this stuff, we've got a new enhanced data standard in place. The flow of data and the insight that it's going to produce in the public domain is immense. And that's around work at the second school rather than one. And that would be, as I say, we have a basis for doing all sorts of exciting things around currency development, focusing on outcomes, paying for good, rewarding good behaviour, getting the level of insight we have. The bit that I'm going to come back to is the 3 strands of activity around extending the scope, so LTC, MUS, SMR, and children and people using the acronyms. And we're doing quite a lot of work, as you'd expect, around commissioning for the future. And the theme there is about how do we take our legacy, bottle it, protect it, and convert it into the new structures in transition. So we're doing quite a lot of work around currency development, quite a lot of work around commissioning guidance, and working with the thing called the Joint Commissioning Panel, which is a joint Royal College, psychiatry and GPs, ADAS, and some of the SHAs involved in that. We're trying to insert our quality standards, which we're going to come to in a second, into the commissioning guidance of the future. And work very extensively with CCG leads through the development programme. So there's quite a lot of activity there. We've also added in a couple of additional programmes for this year, so we've got some additional funding. It's focused on access for older people, which is what that's about, and focusing on equality, particularly for the young groups, as I mentioned earlier. Quite a lot of activity in those areas presently. This is an interesting chart. I wanted to get to this one. Just for fun, I asked a colleague of mine to try and map out all the various initiatives that we're now involved in on a national basis. So the basic building blocks, there's only one place, there's no IAPT service. Anybody from Luton? Good. Well, you won't be embarrassed then, because it's Luton. It's right up the top, right in the centre of the country there. They have got an IAPT service, it's just not compliant. Next quarter that will go green. At which point we have got universal coverage for the IAPT programme, which is a very significant milestone. Overlaid on top of that, there are various pieces of work we're doing in individual economies. The largest chunk of work we're doing is the yellow bits. You can see a few isolated yellow bits, which is children and young people. So there are 40+ sites now involved in children and young person transforming camp services, using some of the IAPT standards and principles around session-by-session outcome monitoring, obsessions with data, evidence-based practice, and transforming the experience of children and people in distress as a consequence. Really, really exciting project. We're doing other work around PDR. We're trying to create an outcome-based currency, as I mentioned earlier. And we've got 22 sites now involved in that. And you can see some combinations of that sort of magenta line. We've got 15 pathfinders working with us about how do you use good quality IAPT services, evidence-based therapies, to improve the treatments of the physical and mental health presentations of long-term conditions in the MUS. That's really quite exciting. We've just launched a bunch of sites around severe mental illness. How do you improve access to psychological therapies for people with severe mental illness? So you've got various combinations. I think Harringay, right at the bottom, is the only one that's got everything going. I think so. That's an interesting place to be. So clear they're up for it. I don't want to dwell on this, but the point is that the reach of the IAPT programme is quite significant at the moment. And I think, if you like, the brand and the quality standards are quite important. And in a sense, they're a very good, useful platform for driving like, a more psychologically minded system, both at organisational level but also at practice level. So I should be bigging that up wherever I can, I think, in the future. We are everywhere. Here's something you can't possibly see. I'm just going to shout out, because I was asked particularly to say what we've learned going forwards. And this is one of the things that says at the top. These are what we regard as minimum quality standards. And they're the sort of observations and conclusions that we've drawn from some of the experience we've had today, year 1 evaluation, various other smaller evaluations of what works, what is important to have in your local services in order to get those outcomes that you want. A couple of things in terms of the service model. Obviously, the nice evidence-based practice is part of this, and the heart of the delivery system there is being able to step your care. So being able to apportion, if you like, the resources to provide low-intensity and high-intensity interventions, and be able to seamlessly transfer individuals between. Employment, which I think will resonate, I think, in this room, but in the rest of today, is absolutely critical. IAPT has had employment advisors and coordinators within their basic services for a while, and I think they're absolutely essential in terms of releasing, if you like, resources and doing right for the clients who come through the services as well. We've got to make sure that we don't lose sight of the fact that we are not about mild and moderate presentations. We do severe and complex comorbid presentations as well. And if we don't do that, we don't realise some of the important benefits. So that's quite important in terms of the model. Access, equity is a critical point there. We've obsessed around self-referral because we know that's a way of getting equitable access moving. And we know actually self-referral drives people completing the treatment as well. So it's very important. Improving patient choice is a very absolutely critical thing in relation to access. So having a range of modalities of treatment available within services, we've been obsessing about that. Treatment is obviously all about nice evidence-based treatments. That's what that section is all about in all sorts of ways. On the outcome, the data collection side, the top right over there, the issuance there is about making sure that we have the data on a session-by-session basis. 90% completion rates, which we've been able to more or less universally achieve, and putting it in the platform so that people can make choices about which service they want to go to. And we can use the data to drive the system and improve, if you like, reward good behaviours for some of the currency developments, for example. A couple of points there about 2 minutes. Right, IT systems, got to be able to talk to each other, got to be able to transfer, particularly because of step care arrangements. And staff training, absolutely important, that accredited training is available, supervisions is based on some of the outcome data, and we actually only have trained staff. There were a couple of final points. Risk opportunities. I suppose the biggest risk in this thing is that where do we go next? How do we make sure that we protect our legacy? We're working quite hard at the department about influencing the mandate to make sure that recovery and the access targets feature in there in some way, shape or form with new language attached to them. We're working very clearly with the commissioning structures, commissioning board, CCGs and health and wellbeing boards. We're using information standard notice and improvement of insights and data as mentioned. We're going to drive a payment by results. It will be payment for the outcomes actually the way we can see it. Any qualified provider, we may want to come back to questions like I see it as an opportunity to standardise and drive our observations, something like that system quite hard. And we're also going to make a contribution to the quick programs wherever they sit, and we think we can do that. And I've got particular issues that are joining up the education and service commission strands. I'm happy to pick up any questions in relation to that or any other matters.
Thank you very much. That's great. Let's move straight on to questions. Just please just say who you are, where you're from, and we'll take a couple at a time. Can I show a hand and see who's interested to ask a question at the moment? I mean, you know, you've got the full state of play as we are currently with IAPT services. You know, where we want to be in a couple of years' time is vital for us. I imagine there's a number of people at commissioning services here. I just want to ask a quick one, Kevin. The point you made. Thank you very much. You're worried about capacity at the moment and commissioning capacity. Can you just be specific what the problem is and what can we do about it to try and alleviate this?
In a nutshell, the most single, if you like, the greatest risk of the programme as I see it, there are a number of risks, but the greatest risk is that we will not have enough workers to hit that 900,000 target. And it's particularly acute in terms of the high intensity therapists. And it's particularly a worry because I know, talking to GPs and others, that they value, if you like, the low intensity interventions, but they particularly value the interventions at high intensity. They tend to be more severe, more complex, more of a challenge. There's no capacity at that level. I think we're going to do a disservice to the initiative overall and not realise the benefits that you can generate. There's a question in the centre here. Get the microphone to you.
Good morning, my name is Monica Schwartz. I'm the Chief Exec of NAPSIAC Intercultural Therapy Centre. We are a voluntary agency who offer very high quality psychotherapy and counselling for BME communities using intercultural therapy. We are involved in a number of IAPT services, but it does seem to me that you're missing quite a lot in not involving the voluntary sector a lot more. Because of the size of the contracts, we're not able to contract on our own, so we've had to join consortia, which we're quite happy to do. But I think when you're talking capacity, especially around the high end, of people who are highly skilled to work with complex needs, especially within the BAPT community, that's where you should be looking.
Okay, that's great. If anybody's thinking of a question, just raise your hand and I'll clock you to bring you in. But if you ask that one, please.
Yeah, sure. I mean, I couldn't agree more. I mean, you know, it makes sense to say that. We had spent a lot of time developing a specific additional workforce. I don't think we've done near enough time about integrating with the pre-existing workforce. And we're doing some work now, because actually it's quite difficult to know who's out there, what they're doing, what their skill sets are. And we're doing some work now to get some insight on that with something called Centre for Workforce Intelligence, which is trying to map the capacity that's out there and try and align it with some of the IAPT quality standards in particular. So we're very interested in doing that. We see actually part of addressing the capacity shortfall is to integrate more fully with what's already in the market.
Great, thank you. And now, of course, there's a flurry of them. There's two now, so gentlemen at the back. We nearly heard you, I think it was Leicestershire.
Hello, yeah.
Oh, that's better.
Liam Herbert, Leicestershire Partnership NHS Trust. We wanted to ask a question about PBR and where you're up to with that, and is there any learning from the national pilot side?
Where we're at, there's nothing to say publicly in relation to the initiative yet. I think I don't know whether you're one of our pilot sites, I haven't got completely called though. Okay. By December, and I think it will be something like we've got a particular deadline, certainly before Christmas, and there's a very important meeting we're aiming at the 13th of December, we will have, if you like, first cut of whether we think we've got something that will work and not completely stabilise the system. The basic model we're going at is trying to incentivise not only effective treatments, but also higher levels of patient satisfaction, other forms of outcomes, so non-clinical outcomes, employment, and so on and so forth. And we think we've got something that will work, and we're getting the data during the course of this week, we're going to get the first cut of data, which we'll cleanse and pass to a colleague who will do some more analytical work on it. So it's too early. I'm hoping we'll have something that will say to the PPR system and machinery, and that's in transition, as you can imagine as well, come December, and then a fully worked up set of proposals around February, which I think will then be further, more widely road tested in the system during 13 and 14.
Hello, my name is Greg Smith. I'm a policy analyst at the Royal College of Psychiatrists. The DH has acknowledged that older people are underrepresented in IAPT services at the moment. And if I understand your presentation correctly, it seems as if there'll be some extra funding to address that. Could you say a little bit about the actual strategy that will accompany the extra funding to actually improve representation in that same client group?
What we're looking for, I mean, there's a couple of specific initiatives. We're trying to make sure that we do work around social welfare, we're encouraging local communities to access, to actually talk, to go to the right places to encourage access from individuals. We're trying to do some work on also GP referrals as well. There's specific initiatives we're doing to improve, like support to carers, which I think is another feature of this. On the specific question, we've got a small pot of money centrally, and we're going to be pushing that at the system, looking for innovative practice, if you like. So is there good practice out there, which is reconciled and evidenced by better access rates than elsewhere? Can we bottle? We understand that, bottle it, push it back as part of the sort of good practice advice. That's one of the ideas we're doing at the moment. It's going to take a while to get there, and there hasn't been the improvements or focus on it until fairly recently. So we've got to make it happen.
Any final question from anybody? The notion of parity of esteem will no doubt be spoken about during the day, but parity of esteem is something that the mental health world are very keen on. So effectively what we're saying is let's raise the profile, let's raise the investment of mental health to equal terms to primary care and acute care. So physical and mental health should interrelate on equal terms. Royal College of Psychiatry are leading piece of work to define exactly what we mean by that and how that will be translated in outcomes. One of the things that will be looked at will be waiting times. Of course, you know, because there's so much demand for IAPT, you know, waiting times, a bit of pressure on waiting times at the moment. I'm sure you're watching that, Kevin, with the notion of parity of esteem.
I mean, it's absolutely critical to us. I mean, the particular interest that we have from the IAPT at the moment is about the long-term conditions and medically explained bit. The sort of mind-body interface bit is the thing we are focusing on. I think we are very worried about waiting times at the moment. We have set our own little standard, if you like, around 28 days, which part of the observation we're getting is maybe that's not entirely appropriate for both low intensity and high intensity, and maybe it's just over ambitious in any case. But we're holding the line at the moment.
Okay, thanks very much. We need to let Kevin go now. He's got an appointment to go to, so perhaps we could just finish by showing our appreciation one more time today.